Beautiful. Okay. Well, welcome everyone. The title took a few iterations, but today the place I landed is the arc of a trauma, right? Really looking at from the initial injury of a traumatic event and then truly the lifespan of it. Not only the trauma, but us as humans and our own identities, all the way up to the end of life and what is available to us at these different points. And one of the reasons I'm doing this talk is because I do think that there are these pivotal moments in life, sometimes after the world sort of rattles us and shakes us, or when we face our own mortality, and that are windows of opportunity, right? Where we can sort of take some of that intense feeling, that loud messaging that our body's giving us, and pause and take a look at what we're doing and where we want to go. In a way, also what we're looking at too is the psychological immune system. So when from a medical model, when there's an injury, how does it kick in? What does healing look like? And knowing what the critical and sensitive periods are. Okay, so I like to just share my biases, backgrounds, and lenses because you might have some very different reactions to the things I'm saying, and you can see where I'm coming from, right? This is not the way. I'm a trauma psychologist. I've been doing therapy almost 20 years now. I also have been in trauma therapy as a patient. So I've done some EMDR, some IFS. I've sampled a lot of things, honestly, as a patient. I was classically trained in the medical model, and that was almost my first language of understanding pain and distress, hospital systems. But the longer I'm in the field, I have a deep respect for some of the more spiritual and humanistic traditions. At the end of life, medicine often has a lot less to say about what can and can't be done and what the answers are. In terms of modalities, I say I'm a trauma therapist. I've really learned a lot of different approaches. If you want to know what some of those acronyms are, you can ask in the chat, and I have a feeling some of the audience members will tell you. But my goal is I'm not kind of polarized in a particular modality. I've been really interested in the core mechanisms and what they're all trying to do for humans who have experienced a trauma or are trying to heal. But that's been a lot of learning over the years. I've also worked as a No One Dies Alone hospice volunteer and a hospital ethicist at the end of life. So in terms of professional training. And then this is a big dose of humility. I have not died, and nor have I experienced PTSD at the end of life. So in that respect, we're kind of all flying blind, right? I'm presuming none of you have died that I'm aware of, and none of us are currently experiencing this. Oh, I forgot to mention my bio. I need to update my bio picture. That's my inner 4-year-old, right? And we're going to talk about that when we talk about parts work, just these more childlike adaptive parts that sort of show up and we carry with us throughout life. Okay. Other considerations for you. We are going to be talking about trauma and death. I think you kind of got that from the title. And know yourself. I work with a lot of people who are so tough and white knuckle through a lot of hard things, but that's really the practice here is just noticing what works for you and titrating it. So I won't take it personally if you hang up in midway. If something is pretty evocative, I always think those are interesting points to pause and notice, like, what nerve is this hitting? Because I have a feeling I'm going to be talking about these big existential things, and you can see where you stand with it. Like I mentioned before, you are in good company. I was looking at the minds that are here listening today, and I'd love to have some questions and discussion at the end. I also am building a directory of people who do this type of work. And so you're welcome to email me. I'll give my email at the end if you want to be added to it, as well as if you want to go to future talks with me. If you sign up for the newsletter at greenwellpsychology.com, that's there. Okay. All right, I've put some art in today, and the art is mostly done by trauma survivors, right? So people who are trying to express their creativity into the world. The recording will be available if you all want it later, and I'll share all my slides if anyone wants it. Okay. All right, what we're going to be doing today, we're going to kind of center on a definition of trauma, talk about pre-trauma experience, talk about the moments, minutes, days, and hours after a traumatic event and the types of interventions that have been found to be helpful or healing, long-term healing, and then end of life. So we could spend hours debating this piece, but for the purpose of today, what I'm landing on, when I say the word trauma, what I mean is a sudden, forceful, and distressing event that overwhelms our capacity to adaptively process it in the moment, such that the enormity of it leads us to quarantine and wall it off. And by that, I mean that it doesn't have to be something that the rest of the world has deemed as traumatic, and it's often very idiosyncratic, right? I've worked with people who've been through horrific things that they kind of brushed off their shoulders, but getting teased in a particular way in the 5th grade has really stuck with them. And if the feeling and the memory of it is so overwhelming that it feels unsafe to contact and process, then we might continue to believe that, and we might kind of segment it off. EMDR, for example, talks about that idea that it sort of becomes this walled off, festering swamp in the river of life. So we're going to talk about what trauma interventions might do there, so that these painful experiences don't continue to impact us in this unintentional, unwanted way, where we're sort of trying to contain it and then it seeps up. First, we're going to talk a little bit about pre-trauma identity. And in my years of working with survivors, it is so clear that trauma does not happen to a blank slate. And I've noticed this when I've done critical incident response to mass traumas, people who are seemingly at the same event, there are very different pain points, right? Because it's interacting with our sense of selves in the world. The other point I want to make here is like pre-trauma identity, it may exist and not exist. There's some research with mice that says the intergenerational transmission of trauma it has been established, right? So you can teach a mother mouse to be afraid of something, and that fear can get transmitted to future offspring, right? And in a way, that's mind-blowing, but that's also something we all know. Many children are born afraid of snakes and spiders, right? And the other thing I want to name is that if it happens early on, developmental trauma, it can really be confusing for us to figure out what is a trauma response and what is just who we are. I just like to be more alone, or I just like, you'll hear people when it's younger not know what's their personality and not know what's an adaptation to survive. But I want to start with an experiential exercise to really kind of bring us into this. And I do this with a lot of the work I do with clients, because I think we live in a world where there's so much information and so much intellectual insight. And so often the underdeveloped muscle is really kind of being with how our emotions and reactions push us around. Okay, so we're just going to look at what your instinctual associations are, and you don't need to share this with anyone. So I want you to imagine later on today that something very unexpected and sudden happens in your life. And just notice like what your mind generates there. Both kind of a feeling place or thinking. And now imagine that it's something that would just be so wonderful to experience. Just something that would make your heart like expand. And then I want you to notice your first and second reaction. Like, observe the trip that your mind took there. How much territory it spent in a dark place versus a light place, how quickly it could pivot. And if I had time and I could sit with all of you together, what we'd find is that there are tens and tens of different responses. And that because of our millions of individual interactions, we are We've all shaped these different algorithms for forecasting and predicting our life and our world and our capacity to deal with it. And what I'm really playing around with right now is uncertainty. And I really, this is coming to be a more and more important issue in psychological health. And so I want to talk about trauma and understanding uncertainty. Because life is inherently uncertain. And there's this quote, if you can't deal with uncertainty, then you're not going to be able to deal with life. And uncertainty, when you've learned to associate that with threat and danger, is highly aversive. We will work so hard to get out of that. But uncertainty associated with hope and awe, well, that can be quite pleasant. That can be exciting, can be curious, it can be intrigue, right? The thing that happens, though, is that trauma can render surprises unbearable, right? There was a particular overwhelming moment that was too much and diminished our capacity to trust that we can cope and be okay, right? And, we want to survive. We want to pass on our genes. So there is a negativity bias. We'll err on the side of caution. There's an interesting study, and maybe put yourself in here and imagine, where they take two groups, and in one group, they say, hey, in 10 minutes, you're going to get a moderate shock. It's not going to injure you, but it's going to be painful. And then they take another group and they say, hey, you got a 50-50 chance of getting a shock. Same rules about the shock. And when they check their physiological reactivity and their stress response, the group that is unsure whether or not they'll get the shock actually experiences more distress and anxiety, right? So in a way, there's this grasping for the known, right? Even sometimes if it's negative. And so we can ask ourselves what our relationship is like with uncertainty and, how it's maybe evolved over our lifetimes. You see this in people, especially later on in life, that it's not an either or, but there are some folks that seem to really kind of let go, and the small things just don't bother them anymore as they age, and then others that kind of clench even tighter, right? And childhood can really teach us and calibrate our perceptions in this baseline nervous system activation. So a secure childhood can, establish this relationship of like, hey, I can usually manage with uncertainty, and I've got some agency and control, and my voice matters. Alternatively, a precarious childhood could teach us the opposite. And I really like this term precarious because it doesn't even have to be traumatic, but just that sense of I'm at risk and something bad could happen is enough to kind of activate our nervous system, right? And if we learn that ambiguity is dangerous, then that does create chronic inflammation in our body and vigilance. And the upregulation over time, it starts to feel really normal, right? And that's why I work with a lot of people with inflammatory chronic health conditions. And it's a type of allostatic stress where they might not even feel it because that's just what they've grown used to, but it puts wear and tear in the body. And then to escape, if we do have a precarious childhood, it's very common for that adaptive child in us to build and rebuild a lot of distractions and defenses, right? Some pretty ingenious ones. If we're looking at the past, maybe it's blaming ourselves to have a sense of control, blaming others to not feel guilty. Sometimes in the future, it might be assuming the worst, setting low expectations, or under or over intervening. Some people say, all right, I'm just taking my hands off the wheel. Other people may say the hands never come off the wheel. Right? And so what we're going to be talking about is how we reestablish safety to some degree. But I'll make the argument that the greater skill is to develop a greater comfort with uncertainty. To have the I don't knows in life trigger less fear. Now, that's provided you're in a relatively safe context and you're not overreacting. If you're still in a threatening space, of course, you need that. And I have this picture of these seedlings there's this hardening process that for any of you who garden and grow seedlings indoor, if you don't expose them to wind and temperature changes, this is what happens when you put them outside, right? And so there's this balance of needing to present enough adversity, but making it digestible. So we don't have that overwhelmed terror feeling that life is too much for us. So I do like to ask this question as a clinician to get at early establishment of coping patterns. As a child, who did you turn to when life felt overwhelming and unsafe? And if the answer is no one or myself, then you're going to look for there might be some strategy like keeping busy, distracting, people pleasing, body focused repetitive behaviors, right? I'm going to pick my hair or skin because it gives me a sense of order and predictability. Yeah. And so people learn these strategies, but then also can reteach themselves when in threat mode, different options. And when you look at the categories of more helpful and less helpful coping in early childhood, positive coping, which is associated with a healing response to trauma, includes things like seeking support, problem solving, reframing the situation. And then you can see the negative ones, which tend to involve more removing yourself, disengaging, distraction. But the two areas I'm going to focus most on today are the immediate aftermath and then also the end-of-life possibilities, because I think they often get neglected. When I work with people after a tragedy, I go through a number of steps that we're going to talk about. But one question that I make sure to always answer, or not answer, ask to get the answer, is what upset you the most? Because I need to know what the pain point is for that person. And I got to tell you, it's very unique to them. So in terms of this psychological first aid, the first thing I'll say about it is I do like the framing of it as psychological first aid, and I think that's very deliberate because, for a physical injury, if you fall and scratch your knee, there are certain givens that we afford ourselves that we don't necessarily do for a psychological issue. So you might stop, assess the damage, give some first aid, take care of yourself, and then take it easy. But when it's a psychological injury, I think there's some norms that we just sort of ignore it. Like, let's say you get corrected in a very embarrassing way in a meeting. We don't typically, we'll deal with the stressor outside of us, but the stress response in us, of like, oh, that hurt. Oftentimes we've been trained to ignore. So a few things that I will raise with people are one, that in this sensitive period after a trauma, further adversity and major life demands are real threats. Like, this is a really time to build a wall and protect yourself. And as a support person in the room, having your own regulated nervous system is incredibly important, right? Because there can be a tendency for both people to co-regulate. And if you leave feeling the same terror as the person you were listening to who went through the trauma, that might mean that you're co-regulating with them and not staying centered. So some other things I do in this initial meeting, if I'm working with someone who's just experienced a trauma, one, normalizing symptoms. So the vast majority of people will have some post-traumatic stress symptoms. That is the body and the nervous system doing what it needs to do and letting them know they're not crazy. Giving them a map when life feels out of control of this is how healing happens and what to expect. So some hope. Checking out for red flags. Encouraging positive coping with a little flexibility. We're going to talk about that. Getting them hooked up with services, and then also helping them access healthy social support. And I make that point because I like this ring theory, and you can see it on the bottom. This idea that those closest to the epicenter of the adverse event should be getting the most support, and those farther from it should be giving more support. So really having the person surround themselves with people who do not place emotional caregiving or other demands on them, right? And you hear this, right? Sometimes, if someone has lost someone and they're at a funeral and they're worried, their grief might be making other people uncomfortable and they're worried. So they're not even able to take care of themselves, right? Without feeling obliged to manage others. Right? The other thing I'll say about this is, well, I'll get to that in a minute, actually. So I do explain to people when I'm giving them a map that PTSD is a disorder of autonomic nervous system. So there's a dysregulation that is very normal. There's some very rough seas, and it's about reteaching your body safety over time. And there's some things that can help the process, right? And so it's very normal to feel like hyper vigilant, overly activated, can't sit still in your skin, and then crash and feel like a zombie. And sometimes I do show some of the pictures of the neuroimaging just to help, help reduce stigma. Like our brains do this. This is our brain refinding equilibrium, right? Where there can be this overactivation and then underactivation. The other thing, if there's grief and loss involved, this is my favorite grief model, where it basically looks at two core processes and this kind of chaotic ping-ponging back and forth. And a healthy healing sign is a little bit of chaos back and forth. So on the left-hand side, that would be connecting with the loss, the sadness, the disappointment, grief work. So a lot of, and then on the right would be restoration, being able to still be in your life, deal with the realities on your path in front of you. Distracting, reclaiming roles that you had taken a break from. And what we want to see is oscillation back and forth between the two. We start to worry, though, when someone is stuck on the left-hand side or stuck on the right-hand side for a very extended period. And this might be different from what someone will say to you, because when we're in the grief, it can feel very crazy and chaotic and out of control, but that actually can be normative and a good sign. So if you're stuck on the left-hand side, that might be this toxic nostalgia where it's like you're frozen in the past, and you might know people who've been there. And then on the right-hand side is more that phobically running into the future. I cannot think of those memories. And that's more of a traumatic bereavement where it almost triggers a threat or fear response to remember what happened. Yeah. And I'm still working on this next thing of like, I want to kind of come up with a category. So it's a draft, but the main point of this slide is that I want people to have high quality deep rest coupled with some compassionate reentry challenges. So not just scrolling on the phone, like with some cognitive arousal or on social media, like deep rest where their body, right? So some healing processes can happen coupled with some challenge, right? So there's not deconditioning. Now, how and when and how much and so on, that's really complicated. That's when I think you can sit with a wise human and say, for my life, for the trauma, for this moment, how much and when, right? When we look at the predictors of non-recovery, there's three things that stand out again and again in the research. One is that coping style. If we lean too much into hiding, avoidance, denial, and disengagement, basically what we've done is we've locked the trauma memory in and we're not getting new corrective information, right? If the world is safer than that moment generally, but we're stuck there and we don't get new experiential knowledge. And again, this is not a logical thing sometimes, right? You'll hear people say, I know it would be fine to walk at night again. I just can't. And so some of it does need to be taught to our bodies, not just our minds. Number two is the severity of trauma. That makes sense to all of us, right? All are not created equal. And then three is social support. So if after a trauma, you're left thinking the world is dangerous and I'm alone, that can fuel this chronic stress response. But there is good news here. So, because when we again and again look at typical trajectories after a trauma, it's quite good. So for the most people, 73%, they have symptoms, but they're not in the disorder range. And then they remain subclinical and heal. So 3/4 of people. And then another 15% of people will have some severe symptoms at the get-go. Their life really is falling apart and they're not functioning, but they recover with time. And then there's another smaller subgroup where they need more active intervention. But this really speaks to the resilience of humans. From a clinician perspective, a few thoughts. Um, in the days afterwards, one of the things I'm looking at is those red flags, like I said, extreme sleep disturbance, extreme distorted beliefs, dangerous coping, things that really could create even more problems in life. But symptoms are totally normal. Sometimes I'll have people come in after and say, 2 weeks after a traumatic event and say, I have PTSD. And while they may have severe symptoms, that's actually normative, right? For them to have some significant symptoms. It doesn't mean that they have a disorder. It means their body's refinding equilibrium. 1 month out, though, I will start checking in with people about what new habits and belief systems have gotten established. Because you don't want some extreme problematic thinking around blame, control, safety, and so on to take root. And then 3 months out, you can start to see maybe a little bit of a trajectory. Has there been healing or not? Right. And again, 3 months is very brief. So not that someone is recovered by any means, but that you're starting to see little sprouts of re-regulating. I think about it, sometimes, I don't know, for folks who have had surgeries, sometimes the surgeon will come in and look at you the day after and you're swollen and there's stitches and you feel like a mess and they might say, "Ooh, look good. You look good." And there can be a similar thing. I mean, you don't want to say it that way as a therapist, where I'll meet people in the days and weeks after and hearing their social support, hearing how they're making sense of what happened to them. I think, okay, this person's going to be okay. This is incredibly painful, but there's a good road. Um, but you are looking to see, is the person starting to re-enter their life compassionately, like in a kind of safe, gradual way. That said, I do want to emphasize the humility thing. We don't, I mean, it's my perspective that self-determination is incredibly important. So if someone decides after a trauma they want to avoid or mourn, who are we to tell them, right? That that's not the right way to live. The other thing I want to bring up with resilience, and I don't think this gets talked about enough, it's called the resilience paradox. And ideally, when we're studying it, we'd be able to parcel out what causes people to heal. The majority of the variance in predicting who heals and doesn't heal, we don't understand. So most of the time, humans are very complicated and diverse, and we can't always predict how people will do over time. And what's a good and bad coping skill is contextual. So for some people, a glass of wine could be a good thing. For some people, a glass of wine could be the worst thing they do, right? Because we're all working with a different set of circumstance. Calling a parent could be the best thing or the worst thing. I like some of these tools I want to mention. One of them was done by a Utah therapist. I don't remember her name, but when someone's expressing extreme despair, it's a checklist, and I could send them out to you if you want them. That's sort of say what you mean to say. And I think it helps people who are in the throes of big emotional storms articulate what they need, right? What is actually going on? And on the right-hand side is a grief registry. And I'd probably rebrand the title. I don't really like the title of a registry, but it's this idea of when we are drowning and something horrible has happened, how can we easily orient people to how to support us? Because we're going to all need different things, right? And again, that's not trauma doesn't happen to a blank slate. For me, as an example, if something horrible happened to me, I would still want to know that I'm not burdening people. And I would also want to know that I could tell you to go away and leave me alone without hurting your feelings, right? But it's going to be different for everyone, right? How you'd like people to show up. I also want to make the point that I discussed some things that would be nice, like reestablishing safety, good social support, some rest coupled with some targeted challenges in the months after. Sometimes that's just not an option. Life does not offer us that. And there are some wise, beautiful people who have alchemized very deep, horrible suffering into some meaningful things years and decades later. I used to lead a World War II veterans trauma group. And gosh, by the time that's what, 60 years plus after the events. And we're going to talk a little bit about that, about what possibilities exist. Let's say you couldn't get the treatment at the time. But some things I just want to mention briefly about longer term adjustment is that what you'll commonly see is that the trauma may not feel as sharp, may not trigger the same intense threat response, but the pain could still be there, right? Instead of a startle response, someone may begin to react with some cynicism. Or if it's healed, you may still hear some of those protector parts warning you, what if you do this? This could happen. But they just don't grip you in the same way. And that's why I kind of think of it as an upward spiral, that we are, in some ways, through the years and through similar life experiences, we're re-encountering similar reminders, but hopefully with some additional perspective and additional safety. One question I'll ask people sometimes, which gives me a sense of how something has been healed or metabolized, is are there old memories that would still make you flinch on the inside when you think of them? And the fact that someone is flinching means that their nervous system maybe is still holding that threat response. Now, sadness, disappointment, longing, those mean that maybe the traumatic fear response has morphed more into grief and been metabolized some. Yeah. So another point I want to make, and that I talk with longer term when people are trying to reclaim quality of life, is that what got you through the trauma does not work for flourishing. So this tools and skills we need for survival mode do not create that sweetness in life. That just, again, like I keep touching my heart. I've become such a woo-woo softie, but like just makes your heart expand, right? And so that takes a risk. Like that takes some getting out of our comfort zone with the hope that there is something, if we soften, available to us, right? And again, some of this is so primal that it's not about thinking our way out of it. It's about creating new patterns, rituals. And one of the reasons I think rituals is so popular is that in our mind, we can just spin, but if we can visually see something happen, right? An act that we do on an anniversary, that can help evolve what's been stuck and stored within us, right? I had this superstition. I had something bad happen to me on a holiday, and I had this superstition where I didn't want to go out of my house on the holiday. And it was totally rational, but that's what my nervous system was saying. And so it was a very deliberate practice of like, yeah, you're going out, which was my choice, right? Everybody reckons their own way. One kind of side note, when I talk about this balance between deep rest and rehab, kind of challenging ourselves, our comfort zone, I do think that's why internal family systems and EMDR have become so popular, because I think if done skillfully, they put trauma into these little bite-sized pieces that we can begin to learn from and safely confront. And I think prolonged exposure, and some of the evidence-based treatments will do that, but you need a skillful therapist who can help manage it so it stays compassionate. The other thing I like to bring up with people is what you practice persists. So I like us to kind of reflect on what our current thoughts and habits are feeding. And, a lot of times, again, it's that statement of like, what got you there will not get you there. What got you here will not get you there, right? If I overwork and I have to get everything in place to feel safe, And then I think I'm going to relax. What I've been rehearsing is overworking. And so the entrenched groove is overworking and it becomes a vicious cycle, right? And I think that's one reason why one of the most important things I think a skillful trauma therapist can do is attend to the manner that the person is engaging with the trauma. Because if you're sitting across from someone, and this doesn't have to be a therapist, it could be anyone listening, and they're talking about it or confronting it, but in a place of terror, what are they rehearsing? They're rehearsing remembering with terror. And what we're trying to do is sort of shift that, right? So the how, this isn't about just gritting it out, because that is, again, reinforcing or training a certain pattern. And so there's these levels of acceptance where I think we on a continuum, we can sort of gently have the person encounter the event. So they can stay with it long enough to bring their wise adult self and learn from it, right? Post-traumatic growth, I did want to touch on that before we switch gears and talk about end-of-life opportunities. The key things here for post-traumatic growth is that it in no way, there can be deep enrichment and learning from trauma, but it in no way negates the bad. In fact, when you look at what it takes for post-traumatic growth to happen, if something isn't traumatic or isn't severely traumatic, it's unlikely to cause growth. So there is a balance where it's both some of the harm or some of the negativity of it is not negated by the fact that there are some positive takeaways, right? Okay, I'm going to talk a little bit about end-of-life possibilities. Let me see how I'm on time. Okay, I'm good. But let me just pause. Amanda, any clarification questions before I move into this last part?
There haven't been any questions in the chat yet.
Whoa, I'm doing it.
You're doing amazing.
Or I'm just talking super fast and nobody's got room. Okay, here we go. End-of-life possibilities. So I picked this drawing on purpose. This is an artist who was drawing about, she was talking about childhood trauma. And if you can look at this painting, she's talking about the elephant of memories holding the cage, right? And then she's also, expressing this desire to move into like a bright, hopeful future, but feeling trapped. And I think that end of life, in a way, does that, where it kind of holds us where we can't run and do all the things and avoid trauma the way we used to. But also, we're not going to be able to just dream into possibilities about the future, right? I mean, if we're aware and not deluding ourselves, we realize I'm never going to be a physician. I'm never going to get to whatever. And so we're being held in this space, right? And I think there's some real opportunities in that, right? Windows that can open for us. I want to just share a little background. So when they look at hospice data, by the age 75, pretty much all humans report they've experienced at least one traumatic event. However, a very small percentage at that point will meet criteria for PTSD. So it really speaks to the idea that there may be these subtle influences for most of us where it's there, but not kind of clinically diagnosable. But trauma reactivation can certainly happen with health conditions. And we'll talk about why that is. But trauma's not the only thing, right? The end of life brings death, anxiety, grief, loneliness, a lot of factors. And when they've looked at how trauma symptoms look different at the end of the life, one, there's a tendency to do more life review, and that can create more intrusions or nightmares. And also, one of the things that can happen is our capacity to compartmentalize can decline with age. So things we used to be able to distract from are harder. There can also be avoidance, right? For example, just disengaging from some decision-making that feels high stakes. There can be a mistrust of other people. And, some real anger and irritability that shows up. impacting relationships. And so I think, especially now when I go into the hospice, I mean, I think the generation now talking about my trauma, it's like there is almost no stigma with the younger folks around saying my trauma, but that is certainly not the case with people generations ago. And so one of the things that can happen is what looks on the outside like anger and irritability could be a sign that internally they're having some re-experiencing symptoms, right? And so some other interesting data here. About 20% of people say that they are having some symptoms, whether it's, it's not full-blown disorder, but they're having trauma symptoms at the end of the life. And I think what's important is that they rated them as very, very upsetting. And so when they were ranking what's most disturbing to them, they were saying they'd rather experience shortness of breath than some of these trauma symptoms. And so that tells us like there's something to be done here, right? There's some real suffering. And that counseling did help. And then when it's untreated, I mean, basically, this is the sales pitch on why it's important to be addressing and assessing. Um, those who did have PTSD at the end of life, they used more services. They rated more physical pain in their bodies. They needed to be prescribed more medications and were at higher risk for other conditions. Right? And that stigma of needing to hide it meant that they were misunderstood and that there were unexplained behaviors that were probably trauma related. This is a tiny graph. I know I made it small, but the bottom line is over 50% of people said, I want to be able to talk about end of life issues with my providers. So clearly it's something on most people's radar. Some other reasons symptoms might surface. Well, I mean, it's interesting. In the DSM-4, the last version, when you looked at the criteria for PTSD, one of the criterion was a sense of foreshortened future. So a trauma symptom was thinking that you were going to die soon. The reality is if you're on hospice, that's just life, right? And so that could be a new trauma. The other thing that can happen is many of us have our safety behaviors and cues in our environment. Like if my closet looks a certain way, or if I get to exercise, or if whatever it is, that help us feel like the world is safe and manageable. And when we start to lose our autonomy and freedoms to make choices about our environment, that certainly can trigger that feeling of out of control. And then, this last one, sometimes there's that call to us of like, okay, here's a last chance to make meaning, to reckon with something. And we'll talk about some case examples in a minute if we have time. In terms of recommended interventions at the end of life, so, initially it would be just doing a brief screener. And I think the key part here is that you're following the client's lead. And it's not a voyeuristic thing of tell me all your war stories. Right? Sometimes, here's an example question. Sometimes illnesses or health problems can bring painful memories or remind us of ways we felt in the past. This is happening to you. Right? Now, let's say someone does want to work with some of this. Stage one, if you just have a little bit of time with them, it would be deferring to their priorities and trying to not trigger the trauma, creating an environment that helps signal more safety to them and control agency. If there's a little bit more time, then you might get to work on some psychoeducation and coping skills. That could be with the family or the patient, just to normalize and support understanding so they don't feel so confusing and the symptoms don't feel out of control. And then actively manage some of the symptoms with medication or coping skills. This graph I thought was really interesting. I haven't seen it for trauma symptoms, but basically the bottom line of this graph is when people don't understand why they're feeling what they're feeling, their symptoms are much worse. So simply being able to explain to everyone, hey, you might get a shot of adrenaline. It doesn't mean you're crazy. It means that that old trauma trigger memory got triggered, and it'll ride out usually within 15 minutes, right? If you can create the container for them. Now, if you've got more time, sometimes there's opportunities for more intensive trauma interventions. One approach I'm going to talk about is meaning-centered psychotherapy. But certainly, there's been good data on all ages of people doing trauma processing therapy, which is just, in my mind, beautiful that like you can get symptom reduction decades and decades later. Now, it's important that they're motivated, they're willing, and they do have the cognitive control to be able to process it, so it's not just flooding them. Um, but let's say the person says, you know what, I'm not digging that back up. Another approach that can contribute to a sense of meaning is called meaning-centered therapy and psychotherapy. And we'll talk about that in a moment. Lastly, I do want to comment on psychedelics. So I could find no studies at this point, and I just done a search yesterday that looked at someone who both has trauma and is at the end of life. There's a lot of research that of psilocybin for existential anxiety, so death anxiety, and then there's a lot of research for MDMA for PTSD separately. And so I would imagine this will be forthcoming, but all of the same kind of potential and warning labels still exist, right? So for some people, psychedelics are never going to be a good idea, and for others, it might show great promise, depending. Okay, meaning-centered psychotherapy. So this is an approach that is being used more and more at end of life, and it's inspired by Viktor Frankl. So he's a psychiatrist who was, some of you might have read Man's Search for Meaning. He and his family were put in a concentration camp. His family was killed, and he was the only survivor. And his takeaway was that meaning must be made, right? That freedom is what you do with what's been done to you. And we all have a responsibility to attempt to build our own sense of meaning, right? And I have these two photos here because he talks a little bit about when you're young, it's almost like this verdant garden often for many of us. Like there is so much possibility, there's so much future, and you can get your nutrients, your meaning nutrients pretty well. You can forage for them and you can find purpose. The older we get, there's a bit of a foreclosure, right? We have fewer options, fewer moves, fewer less strength and autonomy often. But he would argue it is still very, very much possible, right? And that there are approaches and therapies that can help us reclaim that. And so we can find and nurture and feed a sense of meaning. Maybe not happiness, maybe not joy, ease, but meaning. One of the most like a light bulb memory for me was when I was in Japan a few years ago, and I went to this beach, and there was this incredibly frail old man um, eh, who was lying on a surfboard and then surrounded by family carrying the surfboard into the ocean. And he had the biggest smile on his face. And I got to talk to one of the people there, and they basically said, we took him out of the skilled nursing facility. He doesn't have much time left. And he used to be a surfer. He's gonna get to ride a wave. And the like pure joy on this person's face is just stuck with me, right? Um, so in meaning-centered psychotherapy, you are looking at a few different types of meaning. And they're listed there. I won't go through all of them, but there are online trainings at Memorial Sloan Kettering Hospital and a few other places where you can get intensive training in this. If you're going to be a therapist doing this, you need to be able to hold existential distress uh, and have tremendous cultural humility. People are going to tell you all kinds of things they do or don't find meaning in that do or don't resonate. It's very subjective, right? The other thing I'll say that I didn't say is immediate. I'll say this goes for immediately after trauma, but also that end of life work. We have to, as therapists, I think, really adjust our expectations and let go of control. Like, there are things that I so badly wanted for people to have before they died that did not unfold. And then and also similarly, like after going into some of these mass tragedies, I would just leave feeling so, I don't want to say useless, but in a way, like just this, like, did I do anything? And I am convinced that being present and being calm and reminding that there is like goodness and people who care is so important in those moments. But you're not going to get the feedback necessarily from the people because they're in their own grief and trauma, right? Okay. There are a range of ethical challenges. I realize I'm about time, so I'll just send these out as slides but let me just address a few other things. Like I said, I do think there's a beautiful possibility here because at the end of life, because trauma will push us to run and hide and flee. It's very natural. But death is coming at us from the other side. So if the trauma is saying stay alive, survive, and then death is saying that's impossible, it can catch us in this place where we have to pause, and we don't have to. We actually don't have to, of course. Some people don't, but there's a chance to. And it's an invitation, right, to reconsider what do I actually need? Some of these things we thought we needed for safety, we're about to not have safety. We're about to lose our life. So now what matters? And I do think that's the fundamental question is like, can these heartbreak and loss and regrets, we will all have regrets, can they open us up? And I don't know, I imagine many of you have been with people aging and dying, and sometimes you can just walk in the room and feel a difference. There's all kinds of gamuts you runs the whole gamut. I mentioned some of this as providers, but just knowing our own biases and agendas. This was a cool study that said dying is unexpectedly positive. Basically, it studied people at the end of life with cancer and then people on death row and their journals, and that we projected more negativity onto people than what was their actual experience. Right? So I think I'll just close with two brief examples, and then if there's questions, feel free to ask them. But Uh, one of them was a learning experience for me. So this was a person who was on hospice at the end of his life, and I would go to spend time with him. And I got to tell you, at a certain point, I started to get pretty frustrated if I'm aware of my own experience, because he would come in and he would tell the same story about being wronged decades ago by his wife, his ex-wife, again and again and again. And I mean, if I had no filter, I would have been like, oh my gosh, are you really going to spend your last few weeks complaining about your ex-wife from 30 years ago? Which is clearly not the right approach. But being able to step back, what I realized, if I could just be present with this person, what he was saying to me was, that is an injury, that is a wound that I have never been able to heal from. And like, here I am looping on it, and it still hurts me, and I don't know how to get past it. And so when we kind of explored that piece, um, of how much that was actually seen and heard. I came into his room the next time and um, expecting, all right, here we go again. I'm gonna hear the same story. And he said, hey, I don't want to die with gray hair. What's the chance? How can I get my hair dyed? Can I have black hair? And for me, again, looking at what that symbolized was just like that window of like, hey, I'm gonna live in the now for a little bit. I've woken up to today. Um, Another example that has really struck me, and was the first person I sat with as they were actively dying, and she was having some shortness of breath problems, and I remember sitting with her, and all the things I would say as a therapist, or even just as a friend, like weren't appropriate. Like, it's gonna be okay. Um, we're gonna get this fixed. Don't worry. uh, the panic's not real. I mean, it all is real, right? And I went and I spoke with a wise friend who does a lot of this work. Um, and I said, I just kept saying, I'm here. I said, what can I do? What would you have done? And she said, I would have said, I'm here and I'll breathe with you. Can we breathe together in this? Right. And that just like, Like here are two humans sitting in this hard place, and I'm breathing with you. So I was thinking of this talk as I wrap it up. I'm in Utah. I think there's probably a number of folks in Utah, and it's really dark seas right now, right? Things feel pretty intense and tragic. And I guess that's what I'm left with is like no answers, but just like here, can I breathe with you all? I appreciate your attention. I appreciate your care in this topic. And um, I'll open it up to questions.